All right, so as a few more people continue to come in, hello everyone and welcome to this webinar that is hosted by the National Collaborating Center for Healthy Public Policy. Our topic for today is public policy competencies for public health, and my name is Val Morrison. I'm joined today by my colleagues Mylène Maguire, Laila Mahmoudi, and Martin Renaud. Mylène has organized and worked on the logistical support of setting up the webinar and registration, and she will be here and joined with Laila for technical support during the webinar. And Martin Renaud is joining us as a facilitator, so he will be here to help with questions as we move on with the presentation. So a thank you to all three of my colleagues. And just a few notes to let you know the technical things that we need to sort out. And that is that we will be using both the chat box and the Q&A or question and answer box during the webinar. There are well over 400 people registered today, so cameras and microphones are turned off for the participants because that would simply be too much to manage. So, but we will ask you to use the question and A box and the chat box, but we'd ask you to use them for different things. So the chat, please use for any exchanges between yourselves as participants. If you would like to share resources or anything that we have to share, we will put in the chat box. And we'd ask that you reserve the Q&A box that's on the bottom of your screen for questions that you would like us to answer during today's presentation and after the presentation. The webinar will be recorded. In fact, we're already recording, as you may have seen that notification. And that includes the chat box and the Q&A box. So please keep in mind that anything you say, at least during the first 60 minutes of today's webinar, will be recorded and will be available on our website. So keep that in mind as you exchange amongst yourselves. And the recording will be available fairly quickly after today's webinar. If you would like to see it again or pass it on to colleagues, it will be there. We'll also ask you to complete an evaluation, which will appear in the chat box towards the very end of the webinar and will also be sent to you by email. We've scheduled today's webinar for 75 minutes with the idea of presenting for 60 minutes, or that includes some questions and answers, but the sort of formal part of the presentation we will do during the first hour. And then we've scheduled 15 minutes at the end. If you would like to stay, we would very much invite you to. And that is more to have a bit of a discussion, although we'll have to be using the chat and Q&A boxes. But we have some survey questions for you, and we'd like to use that time to explore possible future work in the area of public policy competencies for public health that we might do that would support many of you in your work. So please, if you have those 15 minutes that are scheduled from 2 to 2:15, do stay with us. I will tell you a little, I assume that most of you know, those of you who are joining us from Canada, perhaps though many of you might be newer to public health and not be aware of the National Collaborating Centers for Public Health. So this is a program that was created in 2006 and is funded by the Public Health Agency of Canada. And there are 6 national collaborating centers that are spread around the country, including 2 in British Columbia. That is the National Collaborating Center, or NCC, which I will use from now on to shorten those names. The NCC for Indigenous Health in Prince George, the NCC for Environmental Health in Vancouver, the NCC for Infectious Diseases in Winnipeg, the NCC Methods and Tools in Hamilton, the NCC for Determinants of Health in Antigonish, Nova Scotia, and our NCC for Healthy Public Policy, which is located in Montreal. Tell you just a little bit about our center, the National Collaborating Center for Healthy Public Policy. We, as our name implies, focus on healthy public policies. And what we mean by healthy public policies are those public policies from outside of the health sector that impact on the health of the population. So traditionally, we think of things like housing and transportation, income supports, the built environment, but we might also think, as we have seen numerous examples of over the last couple of years, public policies like limits on retail capacity or on public and private gatherings, on distance learning for school children, and of course, somewhat infamously in Quebec on karaoke singing. But that's a special, we might have a little bit of time to talk about public policy during COVID, certainly a lot of interesting things to discuss about the role of policy, but we won't be concentrating on that today. And before we sort of dive into the material of talking about specifically public policies, we want to take a few minutes to acknowledge that the National Collaborating Center for Healthy Public Policy is located on an age-old Indigenous territory, a place of meeting and diplomacy between peoples and the site of the signing of the Great Peace Treaty. We thank the Kanien'kehá:ka Nation for their hospitality on this unceded territory. If you would like to share a territorial or land acknowledgement from where you are joining us, you may do so. Feel free to do so in the chat box. So just to give us a sense of how the webinar will move forward, we'll give you a little bit of background and context to this work and to why we undertook this scoping review with analysis of public policy competencies. We'll tell you, of course, what the main findings are. And we'll end talking about the limits that we see. And when I say we, I will share this later, but I have a co-author on this work whose name is Audrey Camoignier. She is no longer with the NCCHPP, so she won't be joining us today, but I'm not using the royal we, I'm referring to myself and my co-author. And as I said earlier, we're going to save 15 minutes at the end for discussion about next steps. So to give us a sense of who's with us today, it's always interesting to us to see who registers for webinars or other presentations that we organize, and to get a kind of snapshot for us, but also interesting for you to see who you're in the virtual room with. So as I said, we have close to 450 people who registered. We probably won't get that many participating because oftentimes people will register and then come back and view the video on their own time. But we're still, I can see well over 200 in the room. But of those who had registered as of the beginning of the week, this is good news that 89% of you indicated that you were required to understand the policymaking process in the course of your work. So that's a whopping acknowledgement of how important public policy is to public health. And a small percentage of you don't feel that you need to understand the policymaking process. And then again, a small proportion of you were not sure. When we moved on to the question asking you how confident you were in your ability to understand policy, public policy, and the policymaking process, again, this is usually a degree of familiarity that I would say is unusual, almost 2/3. And if we include somewhat confident and very confident, 3/4, more than 3/4, more than 80% of you feel that you feel some confidence in your ability to understand the policymaking process. So this is an indication that I think public health acknowledges the importance of a familiarity with and an understanding of public policy and the role that it plays in population health. And then the final question that we asked you was about the opportunities you have to learn about public policy and the policymaking process in your work. And again, half of you occasionally have had chance to do that. A quarter split between those of you perhaps fortunate enough to often have those occasions, but 23% of you feel that it would be useful but do not currently have opportunities to learn about policymaking process. So hopefully today's webinar is one such opportunity, and maybe we'll lay the groundwork for other occasions and opportunities for learning about policy. So the NCCHPP has, over the past several years, had many requests or comments and sometimes answers on needs assessment questionnaires or discussions about the increased need for the public health workforce specifically to have greater, more in-depth and more vast knowledge of policy, public policy, and the policymaking process. So we've heard from people in local and regional health authorities who've talked about the need to build capacity for policy and policy work, to hire people who have expertise in this area, and increasingly for the need to implement institutional support. So the public policy and support for public policy work can be integrated into public health, regional and local health authorities. And we've also heard from within schools and programs in public health, for particularly graduate schools, have talked to us about what kind of supports are needed to ensure that students receive their degrees and their educations with a certain degree of familiarity with the effects of policy on public health and also on the policymaking process and how they might be able to intervene in that area. So we started this work having, that is myself and Audrey, having had colleagues within our organization publish a very preliminary competency framework for public policy competency framework for public health actors. That's a lot of P's. In 2015. So a short preliminary, as I said, one that invited feedback and questions, framework for what policy competencies are necessary for public health workers. So we had that and the feedback that we received from that. Of course, many of you will be familiar with perhaps with a number of competency frameworks within your different fields and subfields. And most of us are familiar with the Public Health Agency of Canada's core competencies for public health in Canada. And we're further aware of current work to update or refresh those competencies. So there is not just an increasing interest in understanding public policy, but also a perceived need and a desire to keep those competencies up to date and refresh them periodically. And we are now in a period where there are people working to do that. And so, as I said, we received requests for further work and support in the area of public policy. And there's also a question, as I mentioned at the very beginning, that there may be understanding or lessons to be learned about the way that policy has been made, at least policy that is related to the COVID-19 pandemic, in terms of how quickly policy decisions that affect population health has been made and changed and remade again. So those of us who are students of public policy find that sort of fascinating and think about the lessons that might be learned from everything that has happened in those terms for future public health emergencies. So the main question that we came to this was, because we are not an organization generally that has the mandate or the expertise to devise and publish policy competency frameworks, what we wanted to do was look and see what's out there, what's available in other types of competency frameworks, and what does it tell us about what the public health workforce needs to know in terms of policy. So just a kind of a quick aside here, when we talk about competencies, we're of course talking about the competency approach to learning or to education. So from a pedagogical standpoint, that is a fairly recent, over the last several decades, approach that favors the ability to, the quote that's used there is to know and show. So to come to understand something and to be able to demonstrate an understanding of that, as opposed to another pedagogical approach, which might be the mastery approach, for example, where the goal is for people to master different knowledges in their field. So in the field of education, this competency approach is used in terms of sometimes for admittance requirements, is written into the curriculum, used for evaluation and assessment, so that competencies are not simply things one knows, but it also means that they're used to drive that knowledge forward and to apply that knowledge. And for human resources, competency approach has also been used for hiring, for assessing employees, for issues of promotion, for example. So not simply tied to education, but integrated into workforces, schools, and overall pedagogical approach. So what we're doing here is kind of a marriage between this competency approach and healthy public policy, which is our object. So the question at its most simple level, or in its most simple form, is what do public health actors need to know and show in order to understand and influence policy? And so to find out, or to begin to find out an answer to that question, we undertook a scoping review with analysis that was published in February 2021. The work was carried out a little bit before that, and is available on our website. I think that perhaps Mylène can add a link to that in the chat box if you'd want to check it out. If not, it's easy to find on our website. So we did this scoping analysis to try to find out what categories of competencies existed in competency frameworks and other related literature. And again, I will repeat that we didn't set out to publish a definitive set of policy competencies, but rather to find out what competencies were already being put forth. And so in a sense, a scoping review was the most appropriate, because what we really wanted to know is what was out there. So I will give you the obligatory flux diagram to give you a sense of sort of where we started in terms of number, but you can look up in the document if you're so inclined on our site. There are methodological details, including our search terms, selection and eligibility criteria, but you can find all those in the document. What we did include, we included both scientific and gray literature, and we wanted to include not just existing public policy or public health, sorry, competency frameworks, but also in a few cases, documents that were either compilations of existing competency frameworks, or in some ways were discussions about them. So there were a couple of documents, for example, that reviewed competency frameworks in terms of their relevance for certain workforces or in terms of certain populations. So those were the types of documents that we used. As you can imagine, there were very few. I believe there were two, and one of them we published. So was not something that was unfamiliar to us, but very few public policy for public health competency frameworks exist. What we did find was that most were competency frameworks for public health, where public policy was a subsection or was included in other sections. So what we found and were able to analyze then were 43 documents that were published in English or in French between 2005 and 2019. So really very recently, and we limited that to reflect all of the work that has happened over the last 15 years or so in this area. And there were documents that related either to healthy public policy directly or had a section, as I said, devoted to public policy within public health competency frameworks. So what we ended up with was an exhaustive list of 361 individual competencies that were listed in all of these documents. And through a process of constant comparison inquiry of going through these and of kind of whittling them down into eventually 7 thematic categories and 1 residual category or other, as we refer to it. So we'll talk a little bit about each of those categories. And again, these are not categories that we're suggesting as the most relevant or definitive public policy competencies for public health, but the ones that emerged from the literature and other frameworks that we looked at. So, and I'll talk a little bit about how the sort of relative or weighted importance of each of these, but for now, the competency categories are policy analysis and development. And so this includes competencies that are related to the design, the development, the implementation, the analysis, the impact assessment, and evaluation of policies that are related to public health. So it includes knowledge about how policies are made, how they might impact population health, and the ability to delineate policy options for a specific public health problem using evidence-based data. This category was, as we'll see in a few minutes, by far the most frequently referenced ones. It accounted for 40% of all of the 361 individual policy mentions. The second category is what we called influence or advocacy. So that is all of the competencies that derive from the roles of public health in advocating for policies that improve population health. So advocacy and influence are mentioned in relation to decision makers, stakeholders, community members, as is the ability to take positions on matters of policy that affect health. And this was the second most commonly occurring category. The third category that we identified is partnerships and collaboration. So this includes all of the competencies that are related to forming partnerships and collaborations, so working with community members and community organizations and other people with a vested interest in certain policy issues, and as well as those that discuss the importance of intersectoral collaboration. This category, there's a big drop off from the first two and the next few. So this one accounts for about 14% of all of the individual competencies that were listed. And then very closely in terms of numbers is the competency category of communication. So the competencies in this category are concerned with the ability to effectively communicate with decision makers and the public. And so it includes things like strategic use of the media, but also technical things like writing clear and concise policy briefs and memos, being able to state policy objectives with clarity to different types of audiences. And again, as I said, around 13% of the competencies were from this category. The next one is what we call policy context. So this category includes those competencies that are related to the social, cultural, and political context within which public health intervenes. So that could include things like the knowledge of the population composition, familiarity with the people in the community in which one works, for example, knowing, having a cultural awareness, knowledge about the health systems, the political context, jurisdictional responsibilities that can be particularly complex in Canada, for example, but in many other places as well. So policy context accounted for about 10% of the competencies that were mentioned. The next one, again, and we see a significant drop off here, concerns competencies related to the social determinants of health and questions related to health equity. So this includes all of the competencies that emphasize the importance of social, economic, political, cultural, and environmental determinants of health, and issues that relate to social inequality and health inequities. And then the final of the thematic categories that we found is policy theory. So this includes competencies that emphasize familiarities with different theories of policy, of politics, of public health, of intervention, of social theory, for example, and only a very small percentage, around 1% of the competencies that we found fell into this category. And we had a final category that I suppose we always do have, one that's residual, that we called other, that is made up of competencies that were thematically unrelated to the other categories. And some of these had to do with organizational policies rather than public policies. So things, competencies for translating organizational policy into practice, for example. And sometimes it meant that they were competencies that we were simply unable to categorize or unable to understand precisely what was meant by a certain number of the competencies. We also put in this category those that listed leadership. I'm going to come back to that a little bit later because that's something that sort of stands out in this analysis and that we've reworked a little bit because of the specificities of the way that competency frameworks are written. We will end up sort of reintegrating leadership as a competency, if not a competency category. So when we look at this as a diagram, we can see the share of the 361 individual competencies that were listed fall into one of these 7 thematic categories, or it falls into other. And you can see there, as I said earlier, that policy analysis and development really is the overwhelming favorite in terms of number of times that it's listed as a competency. And that's followed fairly close, or with a big jump, but then follow very closely together influence and advocacy, partnership and collaboration, and communication, and to a somewhat lesser extent, context. And then, as I mentioned earlier, social determinants and equity come alongside other in terms of frequency. So a fairly small number of mentions. Again, we'll come back to that in the discussion. And policy theory, a mere 1%, as I said. Another way of looking at this is the number of the 43 frameworks or documents, frameworks and related documents that we analyzed, how many of them mention each of these categories. So again, we see that for policy analysis and development, it is virtually ubiquitous in all of the documents. There are 2 of them that are missing, and in those cases, I can say that they were not competency frameworks, but were documents that were discussions of or reviews of competency frameworks. So again, virtually everyone considers policy analysis and development to be the most significant competency required in public health. And then again, you can see with numbers like 32 out of 43, again, a very high percentage, same thing, 28, 27, they follow the same sort of order as do the others. I will just like to make a couple of comments about these, particularly the ones which might seem a little bit surprising. And that particularly has to do with the category of social determinants and equity. I think it was really one that kind of fell victim to our methodology, in the sense that the bulk of the competencies that we identified came from subsections of other of competency frameworks so those subsections that dealt with public policy. So in most cases, the social determinants of health and questions surrounding health inequalities or questions of equity were in other sections of the same competency framework. So it's not so much that they're absent or absent, in proportion to the other competencies, but in fact that they're just not covered under the umbrella of public policy. And that's something that could be interesting to discuss. Why is it that they're tend to be kept separate, at least in the existing frameworks? But it does at least allow us to see why that was one of the categories that seemed to come out less often. The other thing that I mentioned earlier, and I will mention again, is the role that leadership plays in all of this, because one of the effects of doing this analysis and of compiling the competencies was that we, what I call, flattened the categories or flattened the levels, because many competency frameworks are layered to attempt to spell out competencies required at different levels of leadership, so that entry or of positions within public health organizations, or in some cases not public health organizations, but they have sort of entry level positions, and these are the competencies, and then manager level, these are the competencies. So in quite a few cases, because there is repetition of the competencies throughout these sort of professional, or on this professional ladder, for lack of a better term, we felt that it would falsely inflate certain categories to have them coming up several times in one competency framework. So we counted them once, and the effect of that was to level off those that dealt specifically with leadership, because most of those, it wasn't the majority of them, but the ones that did separate competencies by type of job description or position, tended to have ones that were set out specifically for leaders, and they didn't tend to change specifically. So the competency might be, for example, be a leader in policy analysis and development, lead partnerships and collaboration, that kind of thing. But because of the way that we treated it methodologically, we kind of lost leadership. And I think clearly that is something that is considered to be an important competency in ways not related to public policy, but certainly in ways related to public policy. So in a sense, as you'll see in a couple of minutes, we think of that as a kind of cross-cutting competency for all of these categories. So we'll take a short pause here, especially if anyone has questions that require clarification, or if you want me to repeat something or you missed something that I might have said more clearly, then feel free to ask it in the Q&A section. Martin has been monitoring the questions, and so I will turn to you, Martin, and ask you if anyone has asked a question.
Thank you, Val. I have a small technical difficulty here, so I lost the questions, but I remember one of the two. One question was about defining policy. So how in your research, in your work, did you define policy specifically?
Yeah, I think what we did, this is something that we have worked on at the NCCHPP, and we have a document there that I think we call it keywords document that looks at how we define public policy as a kind of, or how public policy is defined within our work. In this case, we didn't come in necessarily with an a priori definition of policy, because what we were looking for was what emerged from the literature. And it's a really interesting question, because we did make a distinction as we're doing the analysis between public policy, those that are made by public institutions and government, and organizational or institutional policies. Those were mostly for our own purposes. But what is interesting and somewhat striking is that most competency frameworks that we looked at do not, in fact, define policy, or do not adopt a single definition, a kind of taken for granted that they're public decisions made by those in positions of power or political parties. And that's an interesting question that remains for me, at least, is that we very rarely, in fact, I can't think of a single instance in those, in the competency frameworks where policy is specifically defined. So we essentially respected that and left it there.
There are a few questions that are more open discussion questions about discussions. I'm not sure if you want to leave them for the end, or you want to enter wider discussion at this point.
Probably we should leave them, because I think I've got maybe 8 to 10 minutes, and then we'll have a 10-15 minutes for questions. So if you can just hang on to them. I don't think I mentioned earlier, but you can vote for questions in the Q&A box. So I believe that's referred to as upvoting. If you can just click on the question. If it's something that you would like to see answered, then as I go through the next section, maybe that can help Martin identify final questions. Or not
yeah,
final
so
questions.
don't hesitate to add other questions, and I'll leave it to Val to finish her presentation.
Thanks, Martin. So just to kind of go back and summarize what the findings suggest, or what our analysis from the findings suggests, these 7 categories of competencies. They're not themselves competencies, but categories of competencies, with the addition of leadership as a cross-cutting competency. As I mentioned earlier, because of the way that we analyze, but also because of the way competency frameworks tend to be written, we didn't see that as a distinct category that emerged, but we do think it's important enough to mention that it is there as an important facet of policy work for public health actors in leadership positions. So in terms of the relative importance that was given to these categories, with the exception of the social determinants equity, which was perhaps a bit of a surprise to us at first, except then when we went back, and as I said a little bit ago, saw that those questions were dealt with in other sections of most of the competency frameworks. And this issue of leadership as a cross-cutting competency, the one that did surprise us, and particularly surprised me and continues to surprise me, is that policy theory received very little coverage, very few mentioned in the competency categories. I think it was mentioned in 4 of them, and only in 2 or 3 specifically as theories of policy and the policymaking process. It's certainly something that we have heard in discussions with public health actors, that a feeling that either people don't have time to invest in learning about policy theory, or that it's perhaps too complex in the roles that they are meant to fulfill. But it is something that it seems to me, although it might require some upfront investment, that having a little bit of knowledge grounded in 2 or 3 policy models, for example, policy theoretical models of policy might be helpful. Perhaps you can say if that's something that you find surprising as well, or if in fact you don't think that we need to know the theory in order to understand policy. So some of the limits, obviously I have alluded to the one that has to do with leadership. I think that is in part related to the way the competency frameworks are designed and partly related to the way that we proceeded with the analysis. So the limits, because of that flattening of categories, I'm starting with the second one listed here, but we lost detail and richness in those distinctions between the types of positions that public health actors hold, whether that's frontline worker, manager, in a leadership position, et cetera. And of course, anytime you flatten things, then you lose detail and you lose richness. And a case in point for that in terms of this analysis was the question of leadership. One of the other, and this relates to the question just asked about public policy, was what I would call a relative lack of definition and clarity within the competency framework. So that while, for example, 41 of the 43 frameworks mention policy analysis and development, they don't, in the vast majority of cases, tell us what that means or what they mean by that. And so that, be it as it may in terms of trying to understand, but it makes it quite difficult when you come to seeking to operationalize these competencies. So if you need to know what we mean by policy analysis and development in order to teach it, in order to integrate it into the workforce. So that was definitely something that we saw as a limit within this specific literature that we looked at. And limiting our analysis to public policy, of course, constitutes another limit in the sense that some categories that might be related to policy are excluded. And that is what happened, as I mentioned earlier, to the categories of social determinants and health equity, and also to a lesser extent, there are only a couple of mentions, but we see public health ethics and ethical considerations within healthy public policy have become more prominent in the last few years, and we see the beginnings of that in some of these more recent frameworks. And that may be another sort of omission or exclusion that's related to limiting ourselves to public policy. So the questions that we're left with, the kind of conclusion is where we go with this work for now, is sort of a question that we wish to ask of you. And as I mentioned at the very beginning, we'll be taking an extra 15 minutes or so starting at the end of today's presentation with those of you willing and able to stay and discuss with us. So some of these we'll be able to delve into, but the question that we have is what is useful or what do we want to do to carry this work forward? We know, for example, as I mentioned, that the core competencies in public health in Canada is in the process of being refreshed or revised, updated, and we certainly would be happy to support that work by providing what we've learned about public policy in public health competency frameworks. But is it useful, for example, should we spend time clarifying the meaning of the competency categories with a view to how they might be taught, integrated into public health practice, looking at what kind of institutional supports might be needed to support the work of public health. And that is something that we have been in a position to discuss with different public health both schools and organizations, and that is moving towards something where public policy work or understanding of the policy process and the ability to intervene through these competency categories is something that has been written about before and continues to be talked about in terms of something that is needed within local and regional and in general in public health organizations and in schools. And another possibility is to produce case studies of the successful integration of public policy competencies into public health. There are a few health regions in Canada, and I'm sure there are many that we don't know about, but there are some that have put in place institutional or infrastructural supports for policy work. And then again, as I mentioned, will competencies, there is a chance that they will change in other areas, but will policy competencies change, or can we integrate the lessons that have been learned from what we might call policymaking for or during a crisis over the last couple of years? And then just leave with a conclusion that was drawn by a specific health region in Ontario, but that we've heard resonate in a number of other places, and that is that a more robust and rigorous structure for healthy public policy is needed moving forward. In other words, putting things in place that will aid in allowing the public health workforce to competently and confidently engage with, influence, and understand policy and the policymaking process. So I will stop there for now and go back to Martin. I see that there are a few questions that are there now. So I will ask Martin if are there any burning questions that many people want answered?
Well, yeah, thank you, Val. There are a few very interesting questions. The first theme, I guess, that came up was related to what you discussed about the policy theory and the limited space that it takes, right? So I have a few questions, but I'll try to bring them together. Basically, the question is how come it's expected to create policy, work on policy without using theory? Like, how is that possible? Do you see the contradiction there, or is there anything that can be done? And another question that relates to this is that if you have any recommendation for further professional development on policy theory, right? So how come it exists, this situation where theory is often ignored, and what can be done about it, basically?
Mm-hmm. Thanks. Really interesting question. If I'm completely candid, that could have been a question, the first question could have been one that I sent you because it's something, the reason that I said it was surprising, it is a question that I think I would admit, I would say without reserve that it may be a bias from my own background, disciplinary and experience, but I see a problem with intervening in policy. It doesn't mean that it can't be done, but to understand policy, to understand policy windows, for example, when is an opportunity supposed to open up, and to work, directly on policy, or even in a more distant way on policy, I find it very difficult personally to understand how it can't be done without a theoretical basis. I'm sure that there are ways that it can be done, and I think there are probably a fair number of politicians who find a way to get it done. I don't think that politicians, for example, are necessarily well versed in political or policy theory, but it seems to me something that is important and something that's missing. And I think the person who's asking the question agrees. In terms of resources, that's sort of what we're asking you in general. But we do have a number of resources. There is a section on our website that is devoted to policy analysis. Perhaps Mylène, if you're available, you could link to projects, the policy process and policy analysis. We do have a number of documents there that are they're not really shorthand, but summary versions of different theoretical approaches to understanding policy. It is a challenge in terms of addressing it. I think what I hear from in public health organizations is a lack of time, and it might be a lack of expertise as well. And that might be true in public health organizations and in public health schools. So bringing in people who understand policy theory, and sometimes that means people from political science, for example, or people who have done policy studies, to teach these models. From my perspective, it would be very useful. And I think that people would be able to get a lot from it, but it is a bit disconnected from the day-to-day. And so I think why there's been some resistance or simply lack of availability for that. But sometimes, there are pedagogical exercises that, and many of them exist. And I would have to think about resources other than plugging our own resources. And I can certainly do that and send them if people are interested. But there are sort of, primers on different policy theories and theories of the policymaking process where people can take, for example, a specific policy, start with the policy, try to understand how it might affect public health, and understand, for example, how and when and by whom might further policy change happen. So I hope that answers without being too much.
Yeah, I think so. Another two questions that I'll also try to bring together. There's a question about how public health organizational structures can support engagement in public policy. So how health organization can do something or improve public policy or engage with it. And there's also a question about the results of your work specifically, if there were any unique competency related to health policies. Right? So you mentioned that many of the competencies were taken from public policies in general. Did you identify unique competencies just specific to health policies that are not applicable in other public policies? Does that make sense?
I'm just trying to figure out what the operative word there is. The public from public health omitted intentionally? In other words, health policy as opposed to other forms of public policy, or health public?
I can read the question specifically. That might be better than my attempt at summarizing it. So are the findings generalizable to all public policies since not specified? And are there any unique competencies related to health policies and not applicable to other social and economic policies?
I think I would have to say to that one, and I'll come back to the first question, but that yes, they are related, but I would add to public health policies because they were, by and large, they were public health competency frameworks or documents that commented on that. There were a couple that were a bit tangential. So, these are things that, just from memory. So don't quote me on it, but there were one or two that were dentistry, public health dentistry, so that we're specialized in that way. But there were none that I can think of that were not related to health. So I'm not sure that I would be able to answer that. But I suspect there would be some differences in terms of, again, I'm struggling with the health policy, public health policy, healthy public policy, what we mean there, but the types of policies that affect large groups, subgroups, and entire populations, health, I would think there would be some specificities. And I think it's also the need for public health folks to be cognizant of and involved in policy makes it a little bit more developed there than it might be in other areas of public policy. The first question, could you repeat it?
Yeah, it was a bit more general, basically asking about ideas on how public health organizational structures can support engagement in public policy. So what can health organization can do, basically?
Can do to intervene in policy? Or can do to... Okay, so increase the capacity in a sense of their organizations. There are a lot of suggestions. I think that I'm aware of a few, and because I haven't spoken with them specifically, I won't mention specific health regions, but some of you are probably aware of things like setting up communities of practice. There are some that have set up communities of practice in order to support each other, sometimes with specialized knowledge, sometimes as a more organic discussion. Others have set up policy offices within their health bureau so that if a person is working on a given subject, then they might be able to go to that office, which is realistically one or two people within a health organization, and have their work supported. So show them, what are the policy opportunities? Are there going to be parliamentary commissions on this? Is there, are there publications of the effects of a policy that was adopted elsewhere? Where would I find that, for example? Or how do I find out what groups in the population are likely to be affected by this proposed policy? I'm just sort of making up examples, but there are a number, and I think there appears to be an acknowledgement from those who have started this work, at least, that that's something that's needed, and that's something that will go a long way to helping the public health workforce engage in policy.
I have another question here, more straightforward, and I'm not sure if you covered this in your study, but it asks about ethical competencies in public policy. So did you encounter any references to ethical competencies, or do you have anything to add about this?
Yeah, I did mention it towards the very end. Maybe perhaps it was asked before I mentioned it. Yes, we did come across some mentions of ethical, but very few. Off the top of my head, I can remember two. There might have been a few more, but I think that in part that was, as I said, because we did see a number of frameworks that had sections on ethics, but separate from those on public policy. And I think that we have seen over the last decade, again, this is not something we found, this is my own observation, that we have seen increased awareness of the importance of studying ethics, again, not just of acting ethically, but of understanding ethics and ethics frameworks. Again, and I don't mean to just plug our own products, but we have a section on our website on public health ethics, and a lot of more recent work on ethics. It is, I didn't specifically see that as a methodological limitation. I don't think that we left it out, but I don't think that it has yet been integrated into policy. And maybe that is one way, integrated into policy within competency frameworks, I should add. That may be one of the lessons that we might learn, for example, from the pandemic and policymaking during the pandemic, and how to better integrate ethical considerations into policy processes. But who knows? Again, those are discussions that we are still to have. We're getting very close to 2. Do you have a 30-second or so answer? Well, do you have the question? I'll have the 30-second answer.
I'll try to find questions that you can answer quickly. Well, maybe you did point out to this, but I'll read this question and see if you have something to add. So integrating competencies into public health policy is a critical component. If we can translate policy development into practice, there will be no forward progress. So the question is there any thought towards involving knowledge translation in sharing this information?
Yes. In fact, the way that I can answer that easily is to ask the person who asked it, and anyone who finds that to be an interesting question, to stay with us, because I think that's one of the things that we'll be hoping to talk about, to get sort of your sense of and ideas about how we can meaningfully do that. And I understand the question raises issues about just how difficult it is. I mean, if public health actors are not politicians and they're not policy specialists, for the most part, some of them are. So how to sort of find a balance with enough background and knowledge to act in that field without becoming a specialist. in that field. And it's a difficult balance, and knowledge translation is probably one of the better ways of going about that. So thank you for the question. And again, I will reiterate that we're going to close out in a few seconds. For those, or actually, we're not going to close anything. You're free to leave if you would like at 2. Mylène will be sending the evaluation form. I think she's going to link it in the chat, and you should also receive it by email. And so please do fill out the evaluation forms. They're very useful for us as we consider what to share in webinars, the different formats, etc. So we do take the time to not only look at your feedback, but integrate it into improving, hopefully, our future work, in particular